I am Sanjalil, Assistant of Department of Traumatology and Orthopedics, Samarkand State University of Medical. Development dysplasia of the hip, today's topic. Definition. Developmental dysplasia of hip is defined as partial or complete displacement of the femoral head from the acetabular cavity since birth. Look at these pictures. Risk factors: females, firstborns, familial, faulty intrauterine position. Theories of etiology. Genetic theory. This plastic trait is found in families. Hormonal theory. Hormone introduced joint laxity. Mechanical theory. Faulty intrauterine positions, particularly at the firstborn. Remember, the incidences in DDH, 1 per 1,000 live births, left hip affected in 67% of cases, family history present in 20%. 1/3 cases are bilateral, female preponderance. Pathology. The following pathological changes are observed in DDH, and the severity varies according to the stages of the disease. Bone. Acetabulum, there could be a primary acetabulum dysplasia and acetabulum is shallow. There could be a gap or groove of posterior superior aspect. The triangle of the surface of ilium and acetabulum are in the same line. Above the acetabulum, the depression contains the head of the femur. Head of the femur, the dislocated head of femur at the first appears normal. Ossification is delayed later and head is flat on its posterior and medial aspect. Femoral head, when present in ilium, is buffer on conical shaped. Neck of femur. There could be shortening and innervation. Pelvis. The pelvis is usually tilted forwards. It's small and divided. There's a lordosis and it may be more vertical than capsule. A capsule could show hourglass construction. One tightening head and the other containing heads acetabulum. Construction is produced by liposis and ligamentum teres passes through this constriction and it is hypertrophied. Muscles. Pelvifemoral group, adductors, sartorius, gradual, rector femoris, hamstrings, tensor fascia, lateral muscles. The muscles are shortened and they prevent reduction of the head. Pelvitrochanteral group, obturator, quadrator femoris, lordosis. They are elongated and the process forms as abductus and reduction. Gluteal muscles show little orogenic change but never pelvis diminished. Stages of developmental dysplasia of hip. First, dysplagic stage. Second, dislocatable or subluxation stage. Third, dislocation stage. Clinical features. First is infants, childhood, adolescents, and adults. Clinical features. Galeazzi is sign positive. Ortolani sign of entry is positive. Barlow's provocative test is positive. Delayed walking. Galeazzi sign. The child is in supine position with both the hip and the knee in flexion. The level of both our knee joints are noted with reference to horizontal line. This test is useful in sign unnatural cases of DDH in children between 3 and 8 months. Galeazzi sign. Normally, both our knees should be at the same level. In DDH, the affected knee is seen beneath the horizontal line indicated femoral shortening. The shortening is in the substratocontric region and can be assessed by the brightest triangle. The brightest triangle is there. Look at this picture. Barlow sign. How to perform? This test is done with 2 to 3 days of birth. The infant is supine with the knees fully flexed and the hip of 90 degrees of flexion. This hip is slowly abducted to 45 degrees and the head is slowly pushed towards the acetabulum by the Barlow sign. This test is positive when a joint is dislocated and the femoral head returns to the acetabulum with a click or jerk, reliable and useful up to 6 months, after which the greater trochanter cannot be helped without the middle finger. Ortolani sign. The test is done between 3 and 9 months and is not satisfactory in a newborn. Here, in fact, is supine with the hip and knee flexed. The hip is slowly adducted and abducted to detect any reduction of the femoral head into the acetabulum. Ortolani sign. This test indicated the reduction of the dislocated hip. These two tests are generally reliable and should be performed as a screening tests in all cases of suspected DTH. They are misleading if abduction is restricted to the abduction contractions. Skin fold test of gluteal region. Normally, the skin folds are symmetrical in nature. In this edge, they are no longer symmetrical due to the shortening of the affected limb. Trendelenburg tests. The patient is made to stand first on the normal limb and then on the affected limb. The contralateral leg is then raised from the ground. When standing on the normal limb, the opposite hip is in higher position. But when the patient or the child stands on affected limb, the opposite pelvis drops, indicating impairment of abductor. TTH. Radiograph of pelvis show it in facts. Radiographic examination in infants is of little value, but von Rosen's line is helpful in making an early radiological diagnosis in this group. This is a line which helps in the diagnosis of DTH radiologically, and in fact less than 6 months. It's an anteroposterior view of the pelvis taken with the lower limbs in full medial rotation and 45 abduction. Rosen's line. When the hip is normal, upwards prolongation of the long axis of the shaft of the femur points towards the lateral margin of the acetabulum and crosses the pelvis in a region of the sacroiliacal joint. When the hip is dislocated upwards, prolongation of this line points towards anterior iliac spine and crosses the midline and lower lumbar region. This line is not useful after 6 months. Standard anteroposterior view are preferred in a child older than 6. Ultrasonograms. Graph classification of infant hips based on the depth and shape of the acetabulum as seen on coronal ultrasonograms. Type 1. Normal, characterized by a well-informed acetabular cup with a femoral head beneath the acetabular roof. Type 2. Immature in infants less than 3 months of age and midly dysplastic in infants older than 3 months, characterized by shallow acetabulum with a rounded rim. Type 3. Subluxated, characterized by a very shallow acetabulum with some dysplasia. Clinical features in children and adolescents. Here the patient shows a waddling or sailor's gait. There is increased lumbar lordosis. The deformity frequently encountered in unilateral cases in a shortening. In bilateral cases, both lower limbs are short, perineum is wide, buttocks are broad and flat. Femoral artery is prominently felt. Abduction and lateral rotation movements of the hip are degraded. Trendelenburg tests are positive. Clinical tests of importance in infants are not of relevance in this age group. Lumbar lordosis in the screen. Radiograph of pelvis show it was X-ray. Radiographs of pelvis show in children and adolescents. Unlike in fact, radiographs of pelvis show important features in this age group. The following radiological parameters should be noted. Perkins line, this is a vertical line drawn. Radiograph of pelvis shown in children and adolescents. Hallerden's line, this is horizontal line drawn at the level of treated cartilage. Shenton's line, this is a smooth curve formed by the inferior border of the neck of the female with the superior margin of the obturated foramen. This is broken in DTH. After the tabular index, normal value is less than or equal to 30 degrees. CE angle of Weber, the normal value is 15 to 30 degrees. The Hilden-Reines line and the Perkins line have to access the position of the femoral head. Normally, the headline is lower and inner quadratus formed by these two lines. In DTH, the headlines in the upper and outer quadrants. The continuity of Shenton's line is broken in DTH. The tabular index and the CF angle of Weiberg help to access that tabula. Right DTH in young adults. X-ray examination. H equal A. Horizontal line drawn between the two threaded cartilage shelters of the hip defines a horizontal plane and an approximation of flexion axis of the hips. Hilden-Reines line. P equal A. Perpendicular line to the horizontal line drawn at the edge of bony part of the socket. Perkins line. The center of the femoral head ought to be well within the lower inner quadrant of the crossing of those two lines. S equal N. All that traces the lower pelvis contour out to the smooth contour on the trace the lower edge of the neck of the femur. Shenton's line. X-ray examination. DTH with residual acetabular dysplasia. Radiograph at birth, 3, 10, and 19 years, top to bottom, show persisting dysplasia. Remember, Ortolani's test is a test of entry, relocated at dislocated hip. Barlow's test of exit, dislocated at dislocatable hip. Both these tests lose their significance after infancy. Clinical features in adults. DTH in adults shows all the features seen in adolescents. In addition, patient will have features on secondary osteoarthritis of the hip, namely pain, stiffness, limb, crepitus, restricted movements, and others. Treatment is calm. The aim of treatment in DTH is to achieve and maintain early contact reduction to prevent future degenerative joint disease. Treatment in infants. Reduction can be obtained and maintained by a pelvic hardness, which was first described by Arnold Pelvic, a disease history. Treatment in infants. Apart from the reduction and immobilizations, it allows active movements in all directions except extension and adduction. Nappies can be changed easily. The success rate of this handles is 85 to 95%. However, as the age advances, soft tissue contractures develop along with secondary changes in acetabulum, which bring down the success to right pelvic hardness complications. Treatments between 6 and 18 months. As mentioned earlier, pelvic hardness has no role in the treatment of DTH in this age group. Here, the treatment of choice is gentle closed reduction and hip spice application. Open reduction is done if this method proves unsuccessful. Hip spica application. 9-month-old girl in a hip spica after being diagnosed with DTH. Treatment between 18 and 36 months. In this age group, often reduction in the treatment of choice as closed reduction is often not successful. Open reduction is to be followed with either pelvis or femoral osteotomy to provide concentric reduction of the femoral head within the sternum. Role of osteotomies. Osteotomies are done for instability, failure of vestibular development, or progressive heat subluxation after reduction. They are done only if confirmed reduction is possible, if there is a satisfactory range of movements, or if the femoral head has a reasonable sphericity. The osteotomies could be femoral or pelvic, and the choice is usually left. Pelvic osteotomies are chosen if there is severe dysplasia and if radiographic changes are seen on the acetabular side. Femoral osteotomies. The varus giratorsional osteotomy places the top of the femur in the varus and rotated backward, while the rest of the leg is turned to forward-pointing posture, connecting the two with a metal plate. Femoral osteotomies. This is the procedure of choice if there are changes in the femoral head and if there is an increase in anteversion of the neck. Treatment 8-18 years. In this age group, open reduction is followed by femoral shortening or pelvis osteotomies. If osteoarthritis of the hip develops, total hip replacement in this surgery of choice. Thank you for attention. Take care, guys. Bye.